right, so good morning, everyone, and thank you for taking the time to join us, join ISKI on this webinar about implementation strategies. I know that you all are probably in the midst of your applications at the moment, so time is precious, but we appreciate that you're here to join us, and we hope to be able to provide you information that may ultimately help in your proposals. For those of you who may not have heard, unfortunately, Dr. Sullivan is unable to join us live today, but he did send us a recording of his talk, so that we'll still be able to get his input and his experience. And for those of you, hopefully you all know my face by now, but if not, my name is Dennis Lee. I'm an assistant professor at Northwestern University and one of the faculty for the Implementation Science Coordination, Consultation, and Collaboration Initiative. All right, so on the agenda today, this is not meant to be a Strategies 101 talk. And for that, I'm going to direct you to the recording of Byron Powell's summit presentation, which is located on the ISKI Community of Practice. The link is, once we send these slides around after this talk, you'll be able to kind of use that link to go directly there. But we want to just review some basics of implementation strategies, discuss how they might fit into your projects, either currently or in the next ones that you're proposing. And then, given that we know that there's very few HIV specific examples in the literature, we want to be able to provide you with some examples of early stage and later stage implementation research specific to HIV, and leave time for some questions and discussion at the end. Just a housekeeping check. Can you all hear me okay? All right, thank you. So the NIH defines implementation research as the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings. And so what we can take from this is that based on this definition, implementation strategies should be the central focus of your scientific inquiry in implementation research, either as an intermediary goal that you're trying to get to. So if you're in the more formative stages, at least kind of the short-term goal is to identify which strategies to use. In later stages of IR, it should be the primary focus of your work. So either you're testing the strategy effectiveness or you're comparing two different types of strategies, whereas the intervention effectiveness kind of falls to the backside or takes a backseat to that. By now, most of you should be familiar with this terminology, but I find it never hurts to go over the basics again. And this kind of breakdown, this layman's term breakdown, is actually a teaching strategy that is published in the journal Implementation Science by Jeff Curran this year. It's a one slide that he published, and he discusses the use of it. So just to go through it quickly, the clinical or preventive interventions that you all are trying to put into place in your various settings is called the thing, capital T, that improves people's health. And so implementation or implementing that intervention is doing the thing. Implementation research is our study of how to best do the thing. And then the strategies are other actions or small t things we can do to help other people do the big T thing. Implementation outcomes are how we assess how much or how well we did, or how much or how well others did the thing. So hopefully that was just a quick review and gives us something to think about, in more kind of scientific terms, strategies are the methods and techniques used to enhance adoption, implementation, sustainment, and scale up or scale out of a program or practice. And they can come in many forms. They can be discrete, so single events or actions like reminders, or more often they come in multifaceted or packaged groups, meaning there's more than one discrete strategy being used at the same time, for example, training plus consultation. And these often are also multi-level. They might target the implementers themselves, they might target the leaders, they might target the organizations as a whole. And sometimes they're even protocolized and branded in the literature. So a good example is this Getting to Outcomes program that you might see. It's called the Getting to Outcomes program, but it's not an intervention per se. It's not a health intervention. It is a 10-step process for implementing substance abuse interventions. And each step has a series of discrete strategies that they say to use at each within each of those steps. So relating the strategies to some of our other implementation constructs, strategies target or interact with the contextual determinants, which you've been studying, to achieve the implementation outcomes, which I know from our end, we keep pushing on you. And that, the process by which they do that is the mechanisms that we're trying to elicit. So a caveat here is that there's rarely a one-to-one relationship between strategies and determinants. Multiple strategies can target the same determinants. And on the flip side, multiple determinants can be targeted by the same strategy. However, in the literature writ large, the mechanisms are still largely unknown or very ill-defined in the literature. And so that's one thing that implementation science as a field really needs to strengthen, and what we're encouraging all of our projects to do so that we can contribute to the broader implementation science knowledge. Y'all are very familiar with this by now. So again, keeping in mind that the relationship between determinant strategies is rarely one-to-one, this is just a simplistic representation of how these things fit into the logic model. And these examples are taken from Byron Powell's presentation from the summit. So you might notice that, let's see. So a determinant, for example, like provider knowledge deficit would be targeted by maybe an education type implementation strategy. And the mechanism or the hypothesized mechanism by which that works is that the education increases awareness, it increases knowledge, and that increased awareness and knowledge in turn will lead to more acceptability, more appropriateness, higher adoption. Similarly, training as a strategy may target a skill deficit among your providers, which is a barrier, in order to increase skill acquisition and refinement of the skills, mastery of the skills, and therefore ultimately lead to improved fidelity of delivering the evidence-based program. So these kind of pathways are the ultimate goal of using these logic models, and we hope that the logic models serve as a way for you in your applications and in your other forms of research dissemination, describing exactly why certain strategies were picked to target certain barriers and facilitators. What you might notice, though, is that these pathways are somewhat agnostic to the intervention. Like nowhere on the screen do we say anything about the intervention itself. And this is kind of the level of evidence that implementation research is trying to get to. For any given similar intervention to yours in a given similar context, we ultimately want to know if that particular strategy has evidence of changing and achieving implementation outcomes. Now, we've gotten a lot of questions in our small group discussions as well as our one-on-one coaching sessions about how to best differentiate the strategies from the interventions itself. And I know there's a lot of confusion there sometimes. And we can certainly talk about this more in the Q&A at the end, because there's a lot to say on it. But the most simplistic way we can define this for you is to make you choose from a list. So your clinical and preventive interventions of interest should fit into one of these 7 Ps, as you see listed here. And there should be existing evidence of their effectiveness. So if you're proposing to put into something, an intervention into place that has not been tested for efficacy before, implementation research may not be the right place for it. You should probably be working on some effectiveness study. So the things that you're putting into place should already have existing evidence of effectiveness. And if as you're thinking about the proposals that you're writing, if the thing that you're trying to put into place does not have established evidence, then you may consider whether or not that's a strategy that you're actually testing instead. On the flip side, there are a number of compilations of strategies out there already, or out there in the literature, but the most well-known is probably this ERIC list of 75 discrete strategies. It's not 100% complete, and a few studies since then have added modifications or additional individual strategies, but by and large, the strategies that you pick are going to fit into one of these 9 categories. And as I said, I think our examples will elucidate this a little bit more later on. So to reiterate at this point, as you continue to grow your portfolio of implementation research, the strategies should be increasingly be the central focus of your work, whereas the clinical intervention is going to take a backseat to that. On the left-hand side, you'll see kind of a progression of stages of implementation research. And I think most of the projects in the 65 EHE projects this year are pretty early on and have focused on identifying barriers and facilitators in your particular context. So what we thought we would do next is provide you some resources on helping you kind of move down this chain of research. So based on your identified determinants, if that was the nature of your study, then the next step for you would be starting to select or develop or adapt implementation strategies. And the C4ERIC matching tool, if you haven't heard of it, if you've heard of it, is a good place to start. If you're not familiar with it, this was work done by Byron Powell or Adam Schroeder and a number of other kind of big names in implementation science that took all of the CFIR constructs, the 40-ish, however many there are, 43 I think, and then matched them to the 75 ERIC strategies and try to determine if certain strategies were more effective at targeting certain determinants. They ended up with a decision support tool which you can download for free online. So you have to plop in what are your determinants, and it'll spit out some strategies for you. The tool is not definitive. It doesn't give you a very finite list of things, and the authors themselves kind of note that you know, because there's not this one-to-one correlation, a lot of different strategies can be used for a lot of different determinants. But it does make a good starting point because instead of looking at 75 different strategies, you can at least narrow it down to 20 or so. The second resource, the healthsystemsevidence.org, is a database of research on the empirical evidence behind different systems level strategies. So if you wanted to look to see if a certain strategy has been tested or used in a setting that's similar to yours or on a clinical intervention that's similar to yours, it's a good place to go. And then third, if you wanted to take a more systematic approach to strategy selection, Powell et al. Published a paper on a couple different methods that you could use. So some things like concept mapping you can do in conjunction with your implementation partners and make that a partnered activity. And other things like a discrete choice experiment will take into account a lot of end user preferences, but will require a little bit more resources. And regardless of how you select your strategies, it's critically important that you are very specific about those strategies. So kind of following this diagram, there's a website dedicated to this, is you really want to name what strategy you're using and define it, and then specify it based on who's doing the strategy, who is it targeting, when is it happening, in what dose, is it repeated, or is it a single, a one-time thing? Because I think it's really lacking in the literature right now, is kind of being very specific about these strategies. And so as you study them and as you select them, we want to be kind of increase that specificity so folks can replicate and build on that evidence base. Now, once you've selected strategies, or if that's where you are in your research program, then the next thing you are probably going to do is to pilot or evaluate the strategies. And if you're further down the line, compare 2 different strategies against each other. And here, you know, the big question is about study design and what is the most appropriate study design to assess your strategies. For this, I'm going to direct you to the webinar that JD Smith did a couple weeks ago on designs for implementation research studies. It had a particular focus on small N pilot and developmental studies, so I think very appropriate for this EHE group. And then within that webinar, which you can find on the Community of Practice, he listed a number of different papers that you could also turn to. So I will direct you there for that. And then as you test and evaluate so the strategies in your implementing sites over time, because very often they will adapt kind of on the fly or change. And to really understand how the strategy is targeting the determinants and achieving implementation outcomes, you're going to want to track that use over time. Now, this last kind of type of study, I have it a different shaped bullet because it really can fall in many different places along this continuum of IR research. But it's really the goal is to understand why and how a particular strategy or set of strategies works. This is all about the mechanisms. And so Kara Lewis published a nice article about how to specify the mechanisms that you're studying. And you also just want to measure everything that you can so that you can achieve what they propose, which is kind of causal modeling, to show that this particular strategy targets this particular determinant, whereas this other determinant is actually a moderator, not a mediator, and flesh out all of those pathways. And as you're certainly, I think getting to that level is probably a little further down than where the projects are at now, but for where most of you are, I think drawing from theory, your classic behavioral theories is a good place to start. Because in the end, your implementers are people, the leaders are people, and your strategies are mostly behavioral and some environmental interventions on the system. So now we're going to switch over to two kind of practical HIV examples. The first is going to be an example of an earlier stage IR project in which Patrick Sullivan will explain how they identified implementation strategies for PrEP scale-up based on determinants in the literature. And then I'll come back later and talk about kind of a later stage project where we're comparing two implementation strategies against each other for an eHealth project. This should work.
Good afternoon. Thanks for this opportunity to talk about implementation strategies to increase PrEP uptake in the South.
Sorry.
This presentation really grows out of a paper that I worked on with colleagues Leandro Mena, Leticia Elapre, and Aaron Siegler for current HIV/AIDS reports. And it's one of these times when the invitation to do this paper actually really encouraged us to organize these thoughts and to really synthesize what some of the barriers are to PrEP uptake in the South and possible solutions. So I'm grateful to Elvin Gang for the invitation to provide this piece to the journal. So I'll just start with the reality of inequitable PrEP uptake in the South. And the panel that you see here is an infographic that we produced in association with the release of our county level data sets on AIDSview.org. And it illustrates the levels of PrEP use by region. And there are different ways to look at levels of PrEP use. So the most straightforward way is maybe just thinking about the number of PrEP users per 100,000 population. And if you use that metric, which is outlined here in red, you might say that the Midwest and the South seem like they're doing about the same in terms of PrEP use per population. The West doing better than that at 71 per 100,000, and the Northeast at 106. But the other way to look at this is that we'd like for areas that actually have more impact of HIV to have a comparably higher level of PrEP. In other words, we want to norm our understanding of the level of PrEP use to the level of need. And we do that with the PrEP to need ratio, which is just the number of people using PrEP and over the number of people newly diagnosed with HIV in the same year. So in this case, when we look at the PrEP to need ratio, which is the numbers in blue, we would say that in the West, for every one person newly diagnosed with HIV in 2017, there were over 6 PrEP users in 2018. That's about the same as in the Midwest. But you'll notice that there's a big difference between the Northeast, where there were over 8 PrEP users in 2018 for every 1 new diagnosis in 2017, and the South, where that number was 3. So even though the level or the rate of PrEP use looks comparable between the Midwest and the South, when you account for the fact that the South has many more new HIV diagnoses, and we'd like for the South to have a proportionately higher uptake of PrEP to reflect that high number of diagnoses, the South has the lowest PrEP to need ratio of any region in the country. And when you start to look at maps of related health concepts and social determinants of health, you can see this ecologic pattern play out. And so the map on the far left is the Black population in 2018. The Black population here represented in the darker shades of purple as counties that have 30 to 40% or more than 40% of Black residents in a county. And these are really counties that are concentrated in the South and run in a line that goes from Southern Virginia through North Carolina, South Carolina, Southern Georgia and Alabama, and on into Mississippi. And in the middle panel, where you look at the proportion lacking health insurance, which we'll come back to, that also disproportionately impacts the South. On the far right is the percent of the population with a high school education. So here, more darkly shaded areas have more educated populations. You can see the South really stands out as having a preponderance of counties where less than 81.5% of the population have a high school education. So in asking these questions about why PrEP uptake is inequitably low in the South, we reviewed published literature. We looked at the data on locations of PrEP service providers, data on PrEP utilization from pharmacy data, HIV surveillance data, government data on healthcare providers, and health literacy data to make our assessment. We found that some of the group reasons for lower PrEP uptake in the South are the issues about geography, the low rates of health insurance, low health literacy, stigma of all forms, anti-PrEP, anti-HIV, anti-gay stigmas, lower healthcare capacity, and low HIV risk perception in key populations who would benefit from PrEP. So in terms of geography, the South has the highest proportion of people living in rural counties compared to all the other census regions, about 32%. And in this map, the counties that are shaded in orange and red and rust are counties that are in the most rural areas. And you can see that when I pointed out this line of concentration of predominantly Black counties that runs through Southern Virginia, North Carolina, south of Atlanta, south of Birmingham, and then on into Mississippi, those also coincide with areas that are more rural. We know that that men who have sex with men who live in rural areas are less likely to have been HIV tested, less likely to have been STI tested, less likely to have received prevention interventions, and are less likely to be on PrEP. That rurality plays out in this concept of PrEP deserts. PrEP deserts are areas where people would have to drive more than an hour and a half to reach the nearest PrEP provider. And these are maps developed by Aaron Siegler that use our Emory PrEP locator database of all PrEP providers and then calculate the driving distance between the centroid of each county and the closest PrEP providers. And what that translates to in the South is these areas of rust and red and orange, where men are over an hour's commute, and in some cases over 2 hours commute from the nearest PrEP provider. And these concentrate in that band along the southern Georgia through southern Alabama and up and down the Mississippi River Valley and the border between Alabama and Mississippi. And so these are areas where men are going to have a hard time. This is depicted the number of PrEP eligible MSM who live in these areas that are a long commute away from PrEP providers. The South also has lower rates of health insurance. And you can see that the more darkly shaded areas are areas where more than 14% of the population do not have health insurance. And there's just a stark difference between the Northeast, the Midwest, and the West on the one hand, and the South is the area where some states like Texas, nearly every county has more than 14% uninsured. And this largely has to do with state Medicaid expansion decisions. These are great data from the Kaiser Family Foundation. And here, the states that are in orange, we like to say have not yet chosen to expand Medicaid. But the fact is, I'm going to show you in the next slide that the decision not to expand Medicaid actually has demonstrable effects on levels of PrEP uptake. This is another infographic from our AIDSView site around the release of our county PrEP level data, and it highlights data from an analysis led by Aaron Siegler that looked at county level data and tried to identify policy factors and county level factors that were associated with higher or lower levels of PrEP use. And one of the main findings was that in 2018, PrEP use was higher by about 25% in states that had either adopted Medicaid or had a PrEP drug assistance program. These are programs that offset some of the sort of physician costs associated with taking PrEP. So if you had one or the other of those, that state had a 25% higher level of PrEP use. But if you had both of those, states that had both Medicaid expansion and a PrEP program had nearly double the rate of PrEP use compared to states that had neither. This emphasizes the importance of these policy decisions to facilitating PrEP use. And then low health literacy. These are data that reflect health literacy down to the census tract level. The red areas here are the areas that have the lowest health literacy, and they again run right along this corridor that we've seen play out in some of the other maps. And PrEP is a complicated intervention in some ways. The understanding of the importance of taking it daily, there are requirements to do periodic laboratory rechecks. And so health literacy definitely is a potential barrier to levels of PrEP uptake. And then stigma. This is just one slide to illustrate sort of the potential impact of stigma. These are laws by state that prohibit bullying on the basis of sexual orientation or gender identity. So some states, the ones in Army Green, have laws that prohibit bullying on the basis of sexual orientation and gender identity. And these states are mostly in the Northeast and the West. The South is predominated by states in the sort of khaki color where there are no laws protecting LGBTQ students. And this is just one representation of the extent of sort of lack of protective policies that would also correlate to anti-gay stigma in the South. Low healthcare capacity. These are data from HRSA that show counties in dark blue where the whole county is considered a healthcare provider shortage area. And these affect broad swaths of the South. And again, the South is the most affected region with respect to healthcare provider shortage areas. And finally, low risk perception. We know that low risk perception for HIV leads to low uptake of multiple HIV prevention services, including HIV testing and PrEP. But in both quantitative and qualitative data, Black gay men have reported low HIV risk perception as a reason not to start PrEP. And in focus groups of our cohort of young Black MSM in Atlanta, these men cited beliefs that PrEP was really for men at very high risk and was not relevant to them. And this was in this same cohort, we were measuring around 10% annual incidence of HIV in these young Black MSM, but their belief was that PrEP was for men at higher risk than themselves. And this lack of risk identification and communication are also cited as reasons for not starting PrEP by Black women and trans women in the South. Let's turn to some possible solutions. One of the things I appreciated about Alvin Gang's editorship is that after we sent the first version of the paper, he wrote back and suggested that we try to use the CFER to organize some of the barriers we were describing, the pathways for those barriers, and possible implementation strategies along with the CFER domain. So we've done that in the paper, and you'll see even in the barriers section a lot of the barriers that I've talked about already, and the next section I'll be talking about the possible implementation strategies to address those. So first, let's talking about alternative PrEP provision strategies. Collaborative drug therapy agreements, or CDTAs, are agreements where pharmacists can initiate, modify, or discontinue medications under a collaborative process with a supervising healthcare provider. And 49 states, all states except Alabama, have laws that support this, and this has been used successfully in Seattle to start and maintain people who would benefit from PrEP on PrEP prescriptions. There are also options for care at home. There are national providers for teleprep like Nurex and PlushCare. Aaron Siegler has developed and is testing in a R01 with Ken Mayer. PrEP at Home, which is these mail-out kits for the every 3-month visits that follow PrEP initiation. There's a organization in Alabama that's developed a telemedicine hub and spoke system so that providers who are comfortable providing HIV care and PrEP can be located in urban areas and connect with maybe a room in an FQHC or community health center. In other words, a place where people may be going for diabetes care, hypertension care, well checks, but a room in that maybe one day a week can be for consultation with the infectious disease provider. Considering on-demand PrEP or 211 PrEP, which limits pill burden, reduced costs, and addresses intermittent risk perception. Men saying, I don't have sex that often, so I'm not a PrEP candidate. And finally, streamlining PrEP initiation, which I'll talk about more a bit later. Improving PrEP literacy and education could also help increase PrEP uptake. We have a national action plan to improve health literacy, and the components of health literacy programs that have been shown to be effective are increasing motivation, delivering information in non-written formats. There's a great video called What is PrEP at whatisprep.org that provides the basics about PrEP in an animated format. Use of patient advocates. There are mobile apps that can provide screening for risk for and indications for PrEP and provide education. Tailoring of PrEP education materials to address the needs of specific groups. And peer navigators have been shown to effectively support PrEP uptake and retention in South Africa and are a promising model in the United States as well. Addressing stigma is a big challenge, but there is research that suggests that gain-framed prevention messaging is more effective. Empowerment messaging, this sort of pivot where people may feel stigmatized around taking PrEP, but also may experience empowerment from being on PrEP and taking control of their own health. It's important to understand that these stigmas are intersectional, so the same person may experience anti-gay stigma, anti-PrEP stigma, and racism, and interventions need to address the intersectional nature of stigma. I want to point out the Gilead Compass Initiative has a series of grants called SPARK grants through the Southern AIDS Coalition that are small grants to develop local anti-stigma campaigns. This might be a billboard, a social media campaign that can be developed and deployed, and you can find more information about those grants at gileadcompass.com/spark. And finally, advocacy for anti-gay stigma laws, especially to protect children in schools. Increasing healthcare reimbursement capacity. I think this is about Medicaid, and Medicaid that we need to continue to advocate for Medicaid expansion in the states that haven't yet expanded, and also for PrEP-DAP programs. Remembering Aaron's slide that showed that either one of these was associated with a 25% higher rate of PrEP use, but both of them was associated with a doubling. Low risk perception. There are mobile apps that can help summarize and communicate risk to users. SexPro and Lynx are largely an adult and adolescent version of the same app. HealthMinder and MyChoice is similarly adult and adolescent version. These have risk screeners that will tell men that they may be PrEP eligible for PrEP based on their behaviors. It's a real missed opportunity not to integrate PrEP more closely with STI testing. And in the South in 2016, nearly 850,000 people were diagnosed with STDs, but only about 20,000 started PrEP. So even if we assume that half of those STD diagnoses occurred in people who are living with HIV, that still means that less than 10% of the HIV negative people who were diagnosed with STIs were started on PrEP, and that's a real opportunity. Standing orders or medical prompts in EMR systems to identify patients who may benefit from PrEP. And we've learned in our PrEP cohorts in Atlanta that often a single offer of PrEP is not sufficient. In the young Black MSM that we worked with, we found that the median time between our first offer and their initiation of PrEP was about 4 months. So repeated offering and focusing on PEP to PrEP transitions for men who have either sought evaluation for PEP or have used PEP. They may want to transition to PrEP after. And then streamlining clinical procedures. This it's been demonstrated by the New York City Health Department that it's safe to initiate high-risk people who would benefit from PrEP at the time of their first visit, as opposed to drawing blood for laboratory tests, sending those specimens in, and then waiting for those people to come back to get the results of the lab test and initiate PrEP. And so this has been demonstrated to be safe. If people are found to have a positive HIV test or high creatinine or hepatitis, they can be discontinued from PrEP as soon as those results are back. But for the great majority of people seeking to initiate PrEP, they can start PrEP without having to have a second provider visit. So in conclusion, the reasons for low PrEP uptake are multifactorial, they're intersectional, and the possible solutions span from policy advocacy and policy change to adapting clinical interventions. But in all these dimensions, implementation science is critical, and we need to be focused on outcomes, particularly in underserved and high-risk groups, who, just like I showed that the PrEP to need ratio was inequitable for PrEP use in the South, it's similarly inequitable for women and for racial ethnic minorities. And finally, we need to think about measurement of population level impacts and data sources for evaluation. And so we just have started to release PrEP use data sets at the county level on AIDSview.org. We started with 2018, but we went all the way back to 2012, and we'll update those annually. The National HIV Behavioral Surveillance Survey, which collects data on PrEP use in at-risk populations every third year for heterosexuals at high risk for HIV, people who inject drugs, and men who have sex with men. Travis Sanchez curates the American Men's Internet Survey, which surveys 10,000 MSM in the US annually and tracks trends in PrEP uptake. And also thinking about data from organizations, including FQHCs and community health centers, who we think will be increasingly sources of PrEP provision through the Ending the HIV Epidemic initiative. So thank you for this opportunity to talk about implementation strategies to improve PrEP uptake in the South. And I wish you a good second half of the seminar, and sorry that I can't be there for Dennis's presentation. Thank you.
Thanks, Patrick. So building on his really wonderful example of an earlier stage implementation research project where they started with the barriers and facilitators and then identified strategies that could target those barriers and facilitators. I now want to transition to a kind of a later stage implementation research project that focuses on having an intervention in mind, having strategies already in mind, and comparing those two strategies in a head-to-head trial. So we're going to be talking about Keep It Up and a county randomized comparative implementation trial of that. This group knows very well that the burden of new HIV cases falls disproportionately among men who have sex with men, and this trend hasn't really changed in the past decade. You also probably know that new diagnoses among young men who have sex with men, 25 to 34 in particular, have been increasing despite kind of a flattening or decrease in almost all other groups in this country, both MSM and non-MSM. And this disparity was evident even 10 years ago, which will come into play in a second. So 10 years ago, there was still this disparity that was demonstrated among young men who have sex with men, but the available evidence-based interventions at this time at that time were not commensurate with that disparity. The CDC's compendium for EBIs had very few programs designed specifically for YMSM, and of the few that did exist, they were all delivered in person, either individually or in groups. And so therefore, they had a little bit of a limited reach in terms of the impact that they could make on the YMSM population in the United States. And around the same time, the internet was also emerging as a potential tool for intervention, especially among groups like YMSM. And so Mustanski et al. Developed Keep It Up, which is an online HIV prevention program for young men who have sex with men ages 18 to 29. I'm going to breeze through some of these earlier slides so we can leave more time for discussion. But briefly, Keep It Up uses multimedia stories and activities focused on different life domains relevant to YMSM. It's delivered in 3 episodes, which are the blue, orange, and blue colored boxes, and then 2 booster sessions, one at 3 months later, one at 6 months later. It's designed to be delivered after the receipt of an HIV test result. So a young man who receives a negative test result is also provided Keep It Up so that they can keep up their negative status. The content that you saw on the previous slide was actually from the latest iteration in a long line of Keep It Up versions. Evidence for Keep It Up has been established over this kind of decade-long program of research. Keep It Up 1.0 really looked at the feasibility and acceptability of the program. 2.0 was the fully powered efficacy trial in 3 cities, in which Patrick Sullivan was also one of the co-investigators. And that Keep It Up 2.0 demonstrated a very significant behavioral effects as well as biomedical outcomes with a 40% decrease in STI incidence among Keep It Up participants relative to the control. And so in between, from there, we decided that there's enough evidence to kind of warrant an implementation-focused trial of Keep It Up. And just to note, and these will come up in a second, is in between these kind of NIH-funded comparative trials, we had Keep It Up 1.5 and 2.5, which were service implementation projects in community-based settings, which allowed us to kind of explore a little bit some of the implementation challenges that informs our Keep It Up 3.0 trial. So to reiterate, Keep It Up is now designated a best evidence intervention, risk reduction intervention by the CDC. And specific to that intervention and its implementation questions, over the years, we noticed some interesting anecdotal observations around implementation. So in those 2 service implementation projects in community-based organizations, they didn't exactly deliver Keep It Up in the way that it was originally designed, but they were very creative they used some creative strategies around delivering it. So that was interesting to note anecdotally. And then in Keep It Up 2.0, which was the efficacy trial, we also piloted online recruitment and at-home testing as a potential way to deliver and recruit more participants into the study, which was highly successful. And so there were a lot of questions that were generated around implementation. And then more broadly speaking, for eHealth interventions overall, eHealth has been touted as this really great opportunity for low-cost interventions to be delivered with high reach potential. But and there are a lot of eHealth interventions that have been supported, are currently being supported by the NIH for development and testing. But really, I think overall, we still have a lot of questions around how to scale up eHealth programs. And so this type of research was very much needed in order to understand how to maximize our investments in eHealth. The specific aims of Keep It Up 3.0 are as follows. The main primary aim is really this head-to-head trial of 2 implementation strategies. One is the traditional model using community-based organizations and testing at community-based organizations to funnel individuals into the Keep It Up program. And then the other one is kind of an expansion of the pilot that was done during the efficacy trial of this direct-to-consumer approach. So testing is done at home, at the home of the participants, and then the intervention is delivered directly to them without a need for an implementation broker or anyone in the middle. The aim too of our study is to really understand variability that we see in implementation outcomes, particularly among the CBO side. We know that the direct-to-consumer or DTC side has a central kind of administration, and so there may not be necessarily variation at the implementation level, but there may be variation at the county level. But on the CBO side, we're going to have a lot of variation at the CBOs, and we wanted to explore that using CIFAR constructs. So the design is a hybrid type 3 design, meaning the primary focus is on testing these two strategies against each other, with a secondary focus to ensure that Keep It Up is still effective. We also do measure some individual level outcomes, but they are secondary to our primary implementation outcomes. We use a cluster randomized design in which we selected the 66 counties in the United States with the most YMSM, and then randomized them 2-to-1. So 44 into the CBO arm, 22 into the direct-to-consumer arm. And among the 44 CBO counties, we wanted to use a pragmatic kind of real-world process. So we actually put out a funding announcement and had CBOs from those 44 counties apply. And from those applications, chose 22 counties. So we ended up with 22 DTC, 22 CBOs. We're doing this in 2 waves. So in our first cohort, this map just demonstrates kind of where our counties are. The purple is the DTC counties, the pink is the CBO counties. A unique feature of our design is that our 2 arms, so we have faculty leading each of the 2 arms, and some of whom you may recognize as familiar faces. And a unique feature of our design is that we don't let the 2 arms talk to each other in order to kind of reduce contamination across arms. And the only time we kind of get together and talk is to go over any kind of cross-arm issues like the technology, the methodology that might affect both of them. For evaluation, we are using the RE-AIM framework, which I know all of you are familiar with at this point, so I won't go into too much detail there. And specifically, but I did want to specifically mention to explore the variability in adoption across CBOs, we wanted to use the CIFAR. So this is a really good example of kind of returning to the determinants to help to use as explanatory variables in outcomes. So again, note that we didn't really undergo an assessment of barriers and facilitators for each of the contexts. This is a scale-up study, so we can't go into each of these 44 counties and figure out all the barriers and facilitators there. But we did know enough from previous research about our 2 overarching strategies, the community-based organization approach and the direct-to-consumer approach. And so from there, we had the staff in each side specify all of the different type of discrete strategies that their kind of macro level strategy entailed. So they came up using the same logic model that you're all familiar with. Each arm created their own and specified their strategies. And I'll go through a couple of them very briefly as an example of how we use this logic model to delineate kind of the hypothesized mechanisms. On the left-hand side, you'll see I removed all the determinants, but you'll see the CBO strategies compared to the DTC strategies. And then at the bottom, the Keep It Up platform is an interesting a unique aspect of eHealth in which you can build in some of the strategies into the intervention itself. And I'll kind of explain how that happens. So one of the first strategies we used and this is a selection of them, this is not everything, but one of the strategies we used in the CBO arm was to allow for adaptation and tailoring to the local context. So at the Northwestern level, we worked with the CBOs to switch out some of the intervention content. So there's like a generic welcome video that we could switch out for one that is specific to that community-based organization. And then we allowed the agencies themselves to kind of adapt the delivery of Keep It Up to their own workflows. And we think that this would increase the staff's positive attitudes, the ownership of Keep It Up, buy-in, acceptability, appropriateness, and also potentially to better fit the local YMSM needs in those locations. Utilizing financial strategies is one that we used across both. For the CBOs, obviously we, as part of the funding application process, we have contracts with the CBOs to deliver the intervention, and that kind of meets normal expectations for them. They are allowed to, but not all CBOs are providing incentives for people to use, for YMSM to use Keep It Up. And we'll be able to study whether, those differences across CBOs that do provide financial incentives versus those that don't. In the direct-to-consumer arm, the HIV test and STI test kits are shipped to them free, and that's an incentive. And we're also using non-monetary incentives. But the testing kits, we hypothesize those make testing easier, and therefore access to Keep It Up easier, or the relevance to Keep It Up easier for the YMSM, therefore increasing reach to those populations. We developed stakeholder interrelationships in both arms. Just to highlight a few examples, for the CBOs, we identified and assisted implementation champions at each of the CBOs. So that increases ownership, local control, prioritization of Keep It Up within that organization. Hopefully that means that translates to increased fidelity of delivery. Whereas in the DTC arm, we engaged with local groups at each of the 22 counties. We're engaging with local CBOs, local health departments, advocacy groups. And while they are not delivering the intervention, we're utilizing them to refer people to Keep It Up, or to learn about localized recruitment strategies that we can use to increase reach and awareness to YMSM in those locations. Training and education is one that most people almost everyone should be familiar with. We, in particular, trained CBO staff how to, and our own research assistants and coordinators, how to use and sell Keep It Up to potential participants and how to reach them. So by increasing the skills and engaging and enrolling YMSM among staff in both arms, we're hoping to increase the ability to reach more YMSM. And in the CBO arm, we offer ongoing capacity building assistance, which will help kind of integrate Keep It Up into their normal workflows. Obviously, I think with COVID, things have gotten a little shaky, but it's probably true across the board. We changed some infrastructure, and this, I'll just point out the example of using the Keep It Up platform itself. So in addition to the front-facing aspect of the platform that the YMSM participants see, we also built out a back end that CBO implementers and our DTC staff implementers can use to track participants, see their progress through the different modules, and if needed to kind of ping more on the CBO side, have the staff use that system to ping participants to kind of encourage them to continue and progress through the intervention, thereby increasing fidelity. Similarly, the CBOs can use a variety of techniques to outreach to and engage YMSM to increase enrollment into the program. And then on the DTC side, we actually streamline recruitment so they don't have to have a lot of contact with our staff, as that was deemed a barrier in previous studies. But hopefully that also increases kind of engagement with and enrollment into the program. The Keep It Up platform also has built-in automated reminders, which we consider part of the strategy as well. So just some overarching implications of this work is for e-health, overall, understanding how to best scale out e-health interventions requires some rigorous and pragmatic implementation research, but has the potential to really impact and help end the HIV epidemic because of the ability to reach a lot of people for very little cost. Kind of this second from the bottom up point, but given these two large macro strategies that we had, we thought that Keep It Up would be a good example for you all to see how the IR logic model, the strategies, and the specification of these strategies would all kind of fit together in a later stage IR project. And hopefully the lessons learned from this study will help pave the way for implementing a lot of other e-health programs that are currently either have or currently undergoing efficacy testing. And with that, some thank yous to folks who fund this research. And I know we're a little short on time for questions, but I did want to take any that people had. And I'm happy to stay on for a little while longer if folks have additional questions.
Dennis, hey, this is Amy. Thank you so much. Quick question.
Mm-hmm.
With all those different strategies, I'm not one of those purists that thinks you have to isolate every single effect. But with so many different intervention points, how do you make the case for what you think mattered most? Is that through the qualitative component?
Yeah, that's a really great question. And partially through, I think, the qualitative component, we can start to elucidate which things mattered more. But I think it's also the focus of the study is not a dismantling study, if that makes sense. We're trying to see if the purpose of specifying all of the different discrete strategies within the macro strategies is, for our case, less about dismantling the strategies and finding out the most important components, but more about if someone were to replicate one of our strategies, like direct to consumer, they should be able to, when they're reading our papers or whatever, know what that entailed. So if I just told someone, oh, just do a direct to consumer strategy for that program, that doesn't give any detail. But if we are able to specify a direct to consumer strategy involves A, B, C, D, and E, then that helps aid in replicability and understanding of that strategy as a whole. However, I think a next, a potential future research study would be to say, okay, within a particular packaged strategy, which are the most important? That's a bit of a different research question that we'll kind of get to with some qualitative work in this study, but not the main focus.
Okay, thank you.
You're welcome.
So Dennis, I'm going to highlight, there's just one question in the chat, and this also might be a question for the larger group, but Theo Sanford was saying that they're considering to use the getting to outcomes approach, which I believe is trademarked actually by RAND Corporation and the University of North or South Carolina. So can we use that without involving brand as far as we know?
That I don't have enough information on. I'm not particularly familiar with getting to outcomes other than in name. So unfortunately, I can't provide a lot of detail there.
I will say I did take a quick look at the website. There is a one main contact to reach out to who would probably be the best person to chat with. And I could send that to you via email, Theo.
Any other questions that I can answer? I do want to respect folks' time and thank you for all. Thank you all for participating in this webinar. And should you, think of something as you continue to work on your proposals, feel free to reach out to ISKI if there's still time. Utilize our coaching sessions, and hopefully we'll be able to get a recording of this webinar as well as a copy of the slides up onto the community of practice in fairly short order. So thank you all again for attending and have a great day.